This conference will now be recorded.
Good morning, students. Are you able to hear me? Am I audible? Hello.
Yes, sir.
Morning, sir. Yes, sir.
Good morning. Okay. So today we'll continue with that. Last class we had discussed about cortical mastectomy. So today we'll take up the topic of modified radical mastectomy. Okay. So otherwise known as MRM or canal wall down mastectomy. So it's a surgical procedure where the disease process is eradicated from the middle ear cleft, followed by converting the mastoid cavity, middle ear and external auditory canal into a single smooth self-cleansing cavity exteriorized through external auditory canal. So leaving behind healthy tissue and future reconstruction of sound conducting mechanism whenever possible. Okay, so actually what happened ki previously this mastoidectomy for cholesteatoma surgery was radical mastoidectomy. So radical mastoidectomy was is otherwise known as Joffel or stacked mastoidectomy, and modified radical mastoidectomy is also known as Bondy's mastoidectomy. Okay, so that is radical is Joffel or stacked, and this is Bondy's. So what happened ki previous the thinking was, because the disease was so extensive, they gave more importance to the disease clearance and less importance was given to the hearing mechanism. So the dictum was to remove all the disease process as well as to remove the even the remnant tympanic membrane, and you close off the eustachian tube. You just either use some bone dust or you do knowingly you scar the cause a circumferential scar of the lining mucosa of the eustachian tube, and then automatically it closes off permanently. Now the concept behind closing the eustachian tube is to prevent retrograde infection from the nasopharynx into the middle ear. So now you are isolating the middle ear, and not only that, the posterior canal wall as usual was brought down, and the mastoid and even the middle ear mucosa was also totally removed, and ossicle barring the footplate if stapes is eroded or stapes superstructure is left, and rest all malleus incus all are removed. Even the mucosa, middle ear mucosa, totally it is removed. So that what happened ki there won't be any recurrence. So they were more bothered about recurrence. But as the days progressed, then the concept of uh, preserving hearing came. So then the modified radical mastoidectomy came into existence. And Bondy also described another surgery that is called as a inside out technique or Bondy's technique, where where the drilling starts from the superior from the attic area, and then you follow the what you say the sac of the cholesteatoma as it goes towards the mastoid antrum. What happens here, the superior wall is removed, superior wall of the external auditory canal is removed, and part of the posterior wall of the external auditory canal is removed. Okay, and what happened till you reach the fundus of the sac, you go on drilling, and then once you reach the fundus of the sac, then you stop there, and then the cholesteatoma mass is removed. Okay, so the advantage of this inside out technique was that it produced a very small cavity. Previously, the large cavity used to take time to heal. So till it heals by secondary intention, there will be discharge, and there will be patient will come on and off with ear discharge. So as the cavity size is reduced, the duration of discharge also got reduced, and unnecessary drilling of the mastoid was avoided, and it was also consumed less amount of time. But what happened as but there was other problem which arose. One is the uh, the attic cells were not addressed, and thereby the disease process which were there in the attic cell, they cause lot of recurrence. So this is the reason why the Bondy's procedure went into disrepute, and most of them don't follow it now. So, but then what happened? The modified radical mastoidectomy he proposed, that is a canal wall down mastoidectomy, where the disease control, you get a good disease control, but also you try to uh, improve the hearing by reconstructing the ossicular chain. So the concept is you improve the hearing by reconstructing the ossicular chain. Okay, and this came into existence only after the tympanoplasty procedure came, and then people got the idea that you can graft the tympanic membrane, and then ossiculoplasty came. Then the idea came that okay, we can use the incus to resculpture it and place it over the stapes, so that the person can hear. So all this, once it came, the tympanoplasty Woolston had described, then the hearing preserving concept came in case of cholesteatoma. So objective is to give a safe ear, dry ear. This was these two were there when it started first. But now preservation and reconstruction of sound conducting mechanism is also included. So this can be done as a primary procedure, like once you remove the cholesteatoma, you can go for reconstruction then and there. Or if you are not sure that you have totally removed the disease process, or in certain condition where knowingly you leave out some cholesteatoma epithelium, then in that condition you can stage it and do the reconstruction work after 6 months. Now, coming to indication, the absolute indication is unresectable disease, means there is extensive cholesteatoma, and where unreconstructable posterior canal wall. So the cholesteatoma has also eroded the posterior canal wall so much that you cannot reconstruct it, and there is no what you say no way you can again build up or protect the posterior canal wall. Failure of first stage canal wall up procedure because of poor eustachian tube function. Now, as I told you, as the concept of tympanoplasty, ossiculoplasty all came into existence, then the surgeons became more conservative. They tried what they did. They tried to remove the cholesteatoma mass and also tried to preserve the hearing, try to preserve the ossicles and reconstruct the hearing. So what happened? What they did in case of a small cholesteatoma, they tried to keep the posterior canal wall up as much as possible. And then when you keep the posterior canal wall, you don't drill it, no, then what happens? The middle ear cavity, when you reconstruct, no, the depth or the width of middle ear cavity, you get adequate width of middle ear cavity, which is good, because if the middle ear cavity is of adequate depth, then there will be good amount of air also post-operatively, and that will help in ossicular conduction of sound. But in some cases, it was seen then when a cortical mastoidectomy followed by tympanoplasty was done, there was a recurrence. So when you get a similar case that already patient was operated and underwent cortical mastoidectomy and tympanoplasty, and then patient again comes to you with foul smelling ear discharge, and you can see or smell the cholesteatoma. In those cases, there is no other alternative but to go for a canal wall down surgery. Inadequate patient follow-up. So once you plan to do a canal wall up surgery, means the patient should be religious in his or her follow-up, so that what happens is you pick up the recurrence at the earliest. But if a person who comes from a far off place and is not accessible to you, then in those cases it is always better to go for a canal wall down surgery. Then relative indication is disease in only hearing ear or in a dead ear, and medical illness like uncontrollable diabetes or hypertension, severe otologic or central nervous system complication and neoplasm, like some intracranial complications secondary to cholesteatoma, or patient has developed severe labyrinthitis, okay, or petrositis. So in those cases it is always better to go for a canal wall. And neoplasm, mostly squamous cell carcinoma of the external ear or squamous cell carcinoma of the middle ear. So in those cases also you have to go for a MRM. Uh, and additional relative indication is poor eustachian tube function. So that is why eustachian tube function should be always done before venturing into the surgery. So if a patient has a pathology and the eustachian tube function is not good, and the pathology is a limited cholesteatoma also, it is always better to go for a canal wall down surgery. Then what happens if the eustachian tube function is poor, and then you have done grafted it, and again you have done a canal wall up surgery, then what happens the retraction, then due to poor eustachian tube function, the middle ear is not aerated, and then the middle ear negative pressure develops over time, and then the retraction pocket comes up. And then again after a few years the patient might have a recurrence of cholesterol. Are you able to understand? Hello?
Yes, sir.
Okay, all of you are following now?
Yes, sir.
Okay, wherever there is doubt, you just ask me. So, contraindication like acute otitis media with coalescent mastoiditis, persistent secretory otitis media, allergic otitis media, tuberculous otitis media, and this tuberculous otitis media should be treated primarily with chemotherapy with surgical intervention reserved for persistent discharge. Relative contraindication for open cavity procedure include wide exposure of sigmoid sinus, dura, and facial nerve caused by aggressive disease. Now, see here that no doubt the disease is aggressive, but if the sigmoid sinus already there is a large breach in the sigmoid sinus, and which is very much evident when you do a CT scan or a MRI scan, and if the dura tegment plate is eroded, a large defect is there which is very difficult to reconstruct, then in those conditions if you do a MRM, then what happens the brain, the encephalocele or meningoencephalocele comes into the mastoid cavity, and then it presents in the external auditory canal as a polyp. So to exclude that, to prevent that state, what you do, you keep the canal wall intact. So in that case, what happens? As the canal wall is intact, it won't allow even though the brain or the dura herniate out, no, it remains within the mastoid cavity. It doesn't come into the external auditory canal. Did you understand? Hello?
Yes, sir.
Okay. So that is why even though the disease is aggressive, no, you have to do a conservative procedure and prevent an open cavity procedure, because then what happens is these complications might develop in the future. So, modified radical, also known as complete mastoidectomy and tympanoplasty, is a evolutionary surgical development that attempts to incorporate the major goal of cholesteatoma surgery, that is exteriorization of disease, with sealing of middle ear space to avoid chronic drainage from exposed mucous membrane. So here you are in modified radical and radical, the difference I'll tell you. Although both the surgeries are type of canal wall down surgery, in modified radical what happened, the remnant tympanic membrane is preserved for reconstruction. Ossicles are preserved if they are not involved, and mucosa is preserved. So three things are preserved. So remnant tympanic membrane, ossicles and mucosa, where all these three are removed in case of radical mastoidectomy. Eustachian tube is closed in radical, but it is kept open in modified radical mastectomy. So these are the few differences between a radical and a modified radical. Okay. A primary feature of modified radical procedure is complete removal of posterior canal wall, the major reason for failure of Bondy's procedure. So I told you about the Bondy's procedure, where the posterior canal was not completely brought down, but partially it was brought down. So thereby there was recurrence because access to the mastoid tip was not possible. So if the tip cells are suppose they are diseased, and then you leave it out, then definitely there will be recurrence. So this is the reason why most of the surgeons they abandoned the Bondy's procedure. The Bondy's procedure was predicated on philosophy of limited dissection of the canal wall and mastoid region. And this technique, although often sparing the hearing in the short term, resulted in recurrent cholesteatoma or at least persistent oral discharge because of subsequent infection of remaining mastoid air cells. So this was the problem with Bondy's. And Bondy's operation, the one thing is, you remember, students, key the pars tensa is not touched, and it is presumed that the middle ear is disease free in Bondy's operation. So pars tensa is not touched, and it is presumed that the middle ear is disease free. Okay. So radical mastoidectomy, although effectively dealing with more extensive bone dissection, results in chronic oral drainage because of impossibility of removal of all remaining mucosa in the exposed middle ear. So here you don't, in the radical mastoidectomy, you don't graft them because whatever remnant tympanic membrane is there along with annulus, everything you remove. So there is no question of grafting. So that is what they are saying. It is not possible to remove all the mucosa, even though it is theoretically it is saying that you remove all the mucosa, but it is not possible always because the mucosa near the foot plate area you cannot remove because of chance you may subluxate the foot plate, and then patient will have total hearing loss. Or once the foot plate there is subluxation means, then patient might develop serous or purulent labyrinthitis. So so this is the reason why you cannot remove all the mucosa. So whatever small bit of mucosa is there, no, because it is not grafted, they keep on discharging intermittently. So approaches, basically there are two approaches, endoral and postoral. So here we do most of the cases by our post-oral approach, that is the outside to in technique. And end-oral approach is more direct access to the external auditory canal and middle ear, and more accurate cutting of skin flap is required, and better assessment of shape of the cavity with respect to external auditory canal after operation, and cosmetic scar, because the scar you can hide the scar in a end oral approach. So end oral, the incision is called as the Lambert incision. So Lambert incision, there are two components of Lambert incision. One is the horizontal component and a vertical component. Now here you are seeing this is the horizontal component. The horizontal component starts about 1 centimeter from the outer edge of the external auditory canal. So roughly just medial to the bony cartilaginous junction, just medial to the bony cartilaginous junction, you give a incision from 6 o'clock to from 12 o'clock to 6 o'clock, and then at 12 o'clock you give the second incision vertically, which comes out through the incisura terminalis. So uh, through the incisura terminalis you come out, and then here this is the root of the, this is the called the root of the helix. Okay, so this is the incision, this is the tragus. So you come out through the incision, then you go, then this extension of this incision you can extend it up till here also. There are different that depends upon how much you want to drill. So this is the horizontal incision and this is the vertical incision, and then this incision can be prolonged back till here depending on how much you are drilling in that patient. And while uh, coming out of this, the incision is first made on the skin, and then slowly it is deepened, and then the periosteum is cut. So here what happened, when you extend the incision, two vital structures come. One is a branch of superficial temporal artery which you might cut, so you be prepared for a brisk bleeding, and then you have to ligate it, and the temporalis muscle. So some temporalis muscle also, when you cut, it will bleed. So muscle you can buzz it with a bipolar, but if you cut the branch, the posterior branch of the superficial temporal artery, then you have to ligate. Whereas the post-oral approach or the William Wild's approach, a curvilinear incision, roughly 0.5 to 1 centimeter behind the post-auricular groove, starting from the upper attachment of the pinna till the mastoid tip. So here the wider exposure of mastoid cortex. So here what happens, once you join the two incision, then there is a endoral retractor. You place it here and you retract. So the whole ear comes down like this. If you can you make out, see the one incision and this ear come out. So if you put a retractor here, now this ear comes down like this, comes down like this. So your epitympanum and the external auditory canal is exposed very nicely. Easier access to posterior fossa dura, sigmoid sinus, and Trotman's triangle, but there is greater sensory disturbance of pinna. It's just because the cutaneous nerves are there, lot of them. You might cut a few. A few cases we have seen patient complaining of numbness over the tip, over the particularly the what they call this lobe, ear lobe or lobule. But that is not a grave problem. But the advantage is, oh, you have a wide exposure of mastoid cortex and access to posterior fossa dura or sigmoid sinus and Trotman's triangle. So advantages: residual cholesteatoma is visible on follow-up of a MRM. So and recurrent cholesteatoma is rare. Complete exteriorization of facial recess and second stage is rarely required. So disadvantage, the mastoid cavity problem. So what happens if the cavity you have done, you have operated, and if you have left it like that without reducing the size of the cavity, and then it will take long time to heal. Hmm. And sometimes it may not heal also. We'll come to that why. So this set of patient will always come to you with every now and then discharge from the ear. So that will be very irritating for them, and as a surgeon also it will be irritating for you, because the ear will not be getting up dry, and there will be always some amount of discharge or mm, debris. So why it occurs, I'll tell you. Then shallow middle ear, which is difficult to reconstruct, because I told you the as the posterior bony meatal wall is brought down, no, the middle ear automatically becomes shallow, and then it's difficult to reconstruct. That is one, and the hearing improvement doesn't occur that much. So when you are planning to do an MRM, no, you should counsel the patient that the hearing might go down, in fact, or remain as it is. So you don't promise them that you will have a good hearing, because it is not possible. Because when the three ossicle, the liver mechanism is not there, then the area, the length of the what you say, uh, the difference of length of the handle of malleus with long process of incus, that is also not there. So many factors affect it. And position of pinna may be altered. So obviously depends on lot on the suturing technique, and some cases the pinna may be quite prominent, that is called the bat ear, and some cases the pinna also might be little distorted also if it is not stitched properly. Post-operative vertigo due to caloric stimulation of lateral semicircular canal. So in the canal wall down surgery, no, the lateral semicircular canal, which was previously secluded from outside by the posterior bony meatal wall, is now exposed to the environment. So suppose the patient is when the patient during winter, if he or she drives a vehicle or two-wheeler, as the air cold air enters into the mastoid cavity, and then it stimulates the lateral semicircular canal. So patient, immediately the person will develop severe vertigo and nausea and vomiting. So that also very important. We always advise our MRM cases to put a cotton ball in the ear when they are traveling, or when they, particularly during the winter season. Preoperative assessment. So the decision to perform a MRM depends on extent and location of disease, previous surgery, eustachian tube function, and patient's age, medical condition, and aftercare preference. So already all these things we have touched. Careful microscopic inspection and cleaning of the ear aid in the decision. Pus, mucus, and cholesteatoma debris should be removed under microscopic suction. Once you remove, if there is pus, before doing microscopic removal, it is always prudent to collect the pus and send it for culture and sensitivity. Don't assume that this might be the organ because the color looks this, that. No, it you may think of a single organism, but there might be multiple organisms. So always, if you are getting pus, you take full advantage of that and send it for culture and sensitivity. Polyps can be removed with gentle traction with suction or micro cup forceps, and significant retractions should be, since polyp may be attached to the facial nerve. So what not, I'm sorry, this is typed wrong. You should not pull it a lot. So that is why if you ask me, it's always better not to remove the polyp in OPD procedure, as because if it is attached to the facial nerve, definitely the patient immediately develops facial nerve paralysis. If there is, okay, if the polyp is attached very tightly to the facial nerve or to the matrix of a labyrinthine fistula, then what happens when you remove the polyp? No, the whole matrix comes out and the fistula is exposed. Then the perilymph comes out. So definitely, a patient will develop totally a deaf here. And then stapes superstructure or foot plate. So here the same thing, if it is attached to stapes superstructure or foot plate and you try to pull it out forcibly, then the whole foot plate area comes out and the perilymph which which comes out of the inner ear into the middle ear and thereby causing a almost a dead ear. One, when if the perilymph comes out, obviously there will be a dead ear, but another possibility is that the patient may develop uh, a serous labyrinthitis or a purulent labyrinthitis. Extensive destruction of posterior canal wall with obvious cholesteatoma invading the mastoid indicates the need for MRI. So, active suppuration should be controlled prior to surgery. Now, suppose the patient is having discharge which is foul smelling, creamy, yellowish, or greenish in color. So in that acute phase, you can collect the oral swab and put the patient on a broad spectrum antibiotic, which has primarily a good gram negative coverage. So you remember that in case of cholesteatoma and although it is a mixed flora, but the major organism may be a gram negative organism. So you should select an antibiotic in such a way that it has gram positive activity, but primarily has a gram negative activity. So, and also if you want to cover the anaerobes also, you can include metronidazole or tinidazole in your regimen. So acetic acid irrigation followed by antibiotic ear drop should be instituted for several weeks prior to surgery. So this, what you say, a 2% or 3% acetic acid is a keratolytic. So it removes all the debris. It won't cause any harm. It removes the debris. So thereby what happens? It makes the area clean. And then you can, when the area is clean, no, you can have a good estimate of the extension of disease. So that is why acetic acid is given, and even post-operatively also we advise some patients acetic acid irrigation to remove the debris, and small granulations also can settle down. So acetic acid solution is made by mixing 1 part of white vinegar with 2 parts of boiling water. So when the water is boiled, no, so after it cools down, say you have to check the temperature of the water. So it should be of the body temperature. Neither it should be hot nor it should be cold. If it is hot, then obviously there will be a stimulation, caloric stimulation, and in some patient, if a sensitive patient, there is intense vertigo and vomiting. So then to such an extent you may have to admit the patient and put her on injectable labyrinthine sedatives. So always be very careful and you keep everything ready with you. Don't assume that this is a simple procedure, nothing will happen. So you don't know, some patient might react in a different way. Okay. Preparation are same like a cortical, and infiltration usually the MRM procedure takes time almost 4.5 to 5 hours, depending on if it is a sclerotic mastoid, then it takes a lot of time. So better to do it under general anesthesia. And see, in where you require long duration in case of extensive disease, so general anesthesia is preferred. Now, in a country like India, where we people have the habit of waiting till the last moment, so in a being working in a Apex hospital, you be prepared to always see patient with extensive disease, because these patients will be visiting the practitioners, and those practitioners what they write, they keep on writing these eardrops for years together, and they make their own practice. So that's why by the time the patient comes to you either he or she has extensive disease or might be having some complication. So local infiltration, 2% xylocaine with adrenaline, 1 in 2 lakhs. If not contraindicated, 5 to 10 minutes before incision is made. So if your patient is hypertensive, then you have to omit adrenaline. You have to give only plain 2% xylocaine. So once you give 2% xylocaine, what it does key and wait for 10 minutes, 10 to 15 minutes at least, uh, and this reduces the pain, and the local anesthesia is required. Why? Because as the pain threshold is increased by giving a local anesthesia or even local analgesia, the requirement of general anesthesia medicine comes down. So that is more safer to the patient. Four quadrant infiltration is given at the bony cartilaginous junction of the posterior, superior, inferior, and anterior canal valve. So this is the incision given. Once you give the incision, then slowly you deepen the incision, and the next step is you reach in the periosteum. So this is the periosteum, and then you give a T-shaped incision in the periosteum. So before giving an incision in the periosteum, it is advisable, if you are planning to do a single stage surgery, you can take the graft. But some surgeons, they prefer to take at the end after seeing the defect. So they take at the end of the surgery, they see what defect is left behind and how much of the graft material is required, and they take it. So it is either way, it is correct. Either you take it before the surgery, or you can take at the end. So if you, what the advantage disadvantage is, if you take at the end, you know what defect is there and how much big graft you want. Okay, and how big is your defect and how to cover it. So if you take at the beginning, once you have taken, you assume that this will be this big. So I take this graph, and then I will use this graph. So this assumption is not there. But another advantage is when you are taking it beforehand, now the graft by the time you finish, now it is very dry, and it is very easily and can be easily handled. Whereas a wet graft, no, it is difficult in the in the hands of a beginner to adjust while grafting it at the end. So if you're experienced, then you can do. So the Mollison self-returning hemostatic retractor is placed, and then once you give a T-shaped incision, no, then this you can see it becomes two, one L here and this part here. Then you take a Farabeuf's periosteal elevator, you elevate this side and elevate this anteriorly and this superiorly. So in three direction elevation is there, and then after that you get the mastoid cortex. So when you elevate anteriorly, no, you see the spine of Henle. That is a very important surgical landmark that is called as the spine of Henle. So the spine of Henle, why it is important surgical landmark is because the mastoid antrum lies posterior superior to the spine of Henle, roughly half inch deep from the mastoid cortex. Okay. So last class I had told you always use a cutting burr. You can use a conical burr, you can use a cutting burr, round one, whatever you choose the largest possible size. The largest burr, the chance of injuring the structures beneath the mastoid cortex are less. So use the largest burr and you start drilling. So once you go on drilling now, you remain posterior superior to the spine of Henle. So if when you see this is you are planning to do is a MRM, but still you are preserving the canal wall till the end. Why? Because of two things. One is if the cholesteatoma is not extensive and you have got a good control over the cholesteatoma, you can retain the posterior bony meatal wall. Number one. Number two is uh, for the spine of Henle. So the spine of Henle will tell you exactly where the you should search for a mastoid antrum. So particularly when you are drilling a mastoid bone, no, cortical bone, if it is pneumatic mastoid, it is okay. But if it is sclerotic, then it becomes very, very difficult because sometimes the mastoid antrum will be the only cell present. So, and also that too, it may be of small size or contracted. So to find it out, you need some what you say. You need to rely on one point. So which is that point? That is the spine of Henle. Okay. So when you go on drilling now, and then when you reach the mastoid antrum now, last class I have told you about the corner septum also. So here also you might inquire a corner septum you might come across while drilling, particularly if your patient has a pneumatic mastoid. So in that case you will get a corner septum. So corner septum, how to prove it is by seeing the depth of the middle ear and comparing it with the depth of the mastoid antrum. So roughly the depth of mastoid antrum and the depth of middle ear are roughly the same. If there is any discrepancy, suppose the mastoid depth appears little less, then you assume that this is a corner septum. Okay. Plus preoperative CT scan will clearly define a corner septum. Okay. So another thing, once you open into the mastoid now, one prominent structure you see is the dome of lateral semicircular canal. So this is a landmark in the floor of the antrum. So this is a very important bony landmark to say that you have reached mastoid antrum. One is this, and number two is the adductus ad antrum. So next class we will continue. Any doubt you have? Any doubt?
No, sir.
Acha. Can you tell? Okay. Okay. Thank you. So next class I will complete. Next class. I will complete this modified radical mastectomy. Anything more you want? You please tell me. Any subject specifically you want revision for revision purpose? Hello. Hello. Am I audible?